do you have an equity financing ratio that's negative or emerging risk less than 10%? We also looked at a number of profitability indicators: total margin, cash flow margin, return on equity, and operating margin, as well as liquidity indicators such as current ratio, days cash on hand, and days in accounts receivable, as well as your capital structure ratios, your equity financing ratio, debt service coverage, etc. When we put all your data together, again, this is for 2015, we organized you by size of revenue. Small being under 15 million of revenue, between 15 and 21 million is kind of the mid-size, and over 21 million is being larger. When we summarized all of our data that we had available, what we determined in 2015 is that 10 of the 16 of you really were very stable. Financial risk was quite low. You can see for the low facilities, we had 4 over 21 million in revenue, 4 between 15 and 21 million, and 2 that were in a sense small. We had 2 facilities that were, again, quite stable. We had 2 that were what we would call mid-high risk, where, in a sense, some of the indicators were trending negative. There was, in a sense, some decline happening. And 2 that were of a high risk. So if we total these, for the small facilities, we didn't have any high risk. We had 2 that were mid-high, 1 low, and 2 low. If we look at the little bit larger facilities, mostly were low risk, 1 was at high risk. And then the over 21 million, we had 1 at high risk and the other 5 at low or mid-low risk. This trend, incidentally, or this finding, is somewhat different than some of the other states that we've benchmarked in the recent past. The other states that we benchmarked, most of the high-risk facilities were the small facilities, under 15 million. So what's different about your Wyoming facilities than what we see perhaps in other states? One of the things that we noted is that many of you are getting supplemental funding from some tax funding, tax levies, some type of governmental support that was really, in a sense, keeping you stable. And that's one of the findings that perhaps is different between the facilities in Wyoming compared to the other facilities, particularly those of you that are very small. If we trend you over time between 2011 and 2015, the good news is that there's still 16 of you. All 16 of you made it over this time period. When we took a look at mid-high and high, there were 2 of you in that category in 2011. 2 of you in that category in 2012 and 13, 1 in 14. But in 15, you can see we've got a few more of you for a variety of reasons. Maybe it's big capital projects. Maybe it's a significant financial decline in operating margin. For a variety of factors, there's now 4 of you that we, in a sense, would be watching carefully. If we look at the summary of you from 2011 to 2015, looking at operating margin, we see that the higher margin facilities are getting higher. The lower margin facilities are staying fairly stable. The overall mean or average was a slightly better than a break even, and now it's slightly worse than break even from a total operating margin. However, from a total margin, which includes non-operating activities, contributions, it includes the governmental funding, the tax levies, you can see that really we were fairly stable from where we are from 2011, slightly lower than that. And you can see the trend over time. If we compare you as an aggregate to the state, everyone else in the state, what we see is your total margin in 2015 at 4.8% on average was favorable compared to the U.S. average of 3.1. However, the cash flow and the operating margin, you were slightly worse than the U.S. average. Why the difference? I think part of that difference is the level of funding that you as a community get from tax levy, other governmental funding, contributions, and the like, which pulls you ahead of the group in total compared to the operating margin. So your operating margin is slightly worse, but your funding from other sources, governmental funding and other, is bringing you into a favorable position for your total margin, which ties into the equity financing ratio. From an average daily census, you can see are quite similar to the U.S. average. The Medicare outpatient cost to charge ratio, your average was 56% cost to charge ratio. The U.S. average is about 45%. Again, this is really a function of your charges compared to your costs. So your charges are lower compared to your costs than the U.S. average. We have many more templates that we've shared with Kyle and team that are really more focused on individual hospital performance that we are, in a sense, keeping out of this summary presentation at this time. What I'd like to do before we get to this next part of the presentation is show you what your individual reports are going to be looking like with sample data. This is just what we would call a sample hospital. So the first page of your individual data is from the definitive healthcare data. It includes some information on utilization. What is your utilization trend over time in terms of your days of care, your discharges, your length of stay? We're tracking your inpatient surgeries if that's been reported, as well as your births. We're tracking your case mix index. How complex is your care? That's on the inpatient side. On the outpatient side, we're tracking your ED visits and your outpatient visits, giving us a sense of patients into your facility on average per day. We're also tracking the available quality metrics. And the one that we're really tracking is your hospital-wide readmission rate compared to a benchmark and compared to time. Are you getting better or worse? Patient would recommend ratio compared to the benchmark and the overall star rating. We're also tracking your financial activity, again, very, very summarized over time, as well as our risk rating over time, and some benchmarking, operating margin, total margin, equity financing ratio, and if you did have any affiliation that we were aware of, we documented it here. You'll also see some narrative in terms of our high-level observation from this sample definitive data on this first page, giving you kind of an overall storyboard. The second page that you'll see is from the Flex data, not the definitive data. Again, this is a Flex-funded project, so we wanted to use where we could the Flex information. So we're trending over time, and U, which is in blue, compared to the Wyoming median for all critical access hospitals, your operating margin, your total margin, your equity financing ratio over time, your days in net accounts receivable over time and how you compare, as well as the data that we receive directly from the Flex program. On this page, when you get your data, shaded in yellow, kind of where we saw you on a percentile basis rather than just compared to the median. So, you can kind of see on this page where this particular hospital aligned with some of the more detailed metrics. And then on the far right side, we've got the national benchmark. What does good look like? What does good look like? So you can, again, look at this data as well as your data and see how you compare to a national benchmark. And lastly, we've provided some small amount of narrative on this page compared to what we saw from your particular data. So each of you are going to get, in a sense, these slides with respect to your specific hospital information. Now I'd like to turn to, okay, well, what does this mean and what should we do about it? As we work with critical access hospitals around the country, the first thing that we like to, in a sense, highlight is to make sure our critical access hospital community understands the key drivers, the drivers of financial success, because then we can start focusing on improvement efforts related to one or more of these drivers. So let's start with the revenue drivers. What we see with the critical access hospital community, the drivers of success are your market size and your market share, your units of service provided, your mix of service, your payer mix, and your reimbursement per unit. These are all elements that are driving revenue or reimbursement within your organization. Expense drivers, we look at your labor, which is hours and rates, your non-labor expense, your supplies, which is the cost and the quantity that you use, your services, which is contracted cost and the quantity of that service, and your capital investment, your facility life cycle, your usage of space and equipment, and the cost input. Some of you that were leaning toward a higher risk facility, we could see that you invested a significant amount in capital very, very recently. And that, in a sense, might have turned the table for you from being at lower financial risk to higher financial risk, because now you have some significant debt on your investment that you need to fund in addition to funding your operations. So if we think about the common challenges for critical access hospitals related to expense drivers, or revenue drivers rather, one of the first things that we see is that there's a slow migration of services to larger facilities in the region, possibly due to a perception that bigger is better. But we need to think as a community of care that care is getting much more integrated, and that we need to, in a sense, develop a strategy for keeping what you can do and do very well local. And that's really one of your challenges. The service delivery model may not be providing quality care. Again, this may be a perception, and you must understand and use the quality metrics that are publicly available in order to, in a sense, discredit this bias or this perception. Your mix of service may be dominated by Medicaid and other low payers. This is absolutely a big issue for you, and this is why many of your governmental agencies are supporting the funding of your organization. And that's a very positive finding that we see in the state of Wyoming. Commercial payers are using market power to reduce reimbursement or limit services. Again, this is a challenge that we must overcome through contracting and other methodologies as we think about possibilities for the future. And the last one, again, with tremendous possibility for improvement, is ineffective revenue cycle processes not capturing reimbursement. As we do revenue cycle projects for critical access hospitals around the country, we find error rates in coding, error rates in charge capture, error rates in billing, and in getting paid the right amount. And when you add all those errors together, our average error rate for critical access hospitals is often 50% or more. Opportunity to capture likely 2 to 5% more reimbursement by more effective revenue cycle processes. On the expense side, what we typically see as common challenges is significant standby staff in the ED, in the nursing unit, in the OR. We're paying for people to be there without patients. How can we mitigate that cost? We also see that critical access hospitals often have limited negotiating power for supply contracts as a standalone entity. But what about if we band together? So that's another possibility. The other thing that we see is low service volumes negatively impacting our per unit of cost service. This is a finding that's absolutely true, and this is why we need to get paid differently as a critical access hospital from our commercial payers. Commercial payers love to get you on a fixed unit of service cost. This doesn't work well for you with small volumes and very high fixed costs. And we need some contracting power in order to make sure that this doesn't happen. The low service volumes also impact negatively the cost of our equipment and facilities on a per unit basis. So again, what can we do about this? So here we are with our strategies. And as we talk about the strategies, we can talk about possibilities for using flex funding and integrating with Kyle and her team in terms of possibilities. The first strategy is really a market or service assessment. Understand who your facility is serving, what percent of your market are you capturing. Can you be a market leader in the primary service area for services for which your facility excels at? Primary care, chronic care management, behavioral health integration. Can you collaborate with larger facilities on certain care cycles? Is there a win-win to be had in your service area, in your market region? Understanding the market potential for services based on buyers in your market. And developing a financial model to understand if you could have a market shift occur, what impact would that have on you from a market perspective? Again, market and service assessment is something that could help you understand the possibilities in your market. Other revenue cycle possibilities. Again, if you're not well funded by Medicaid, are there other reimbursement sources? Many of you are, as I said earlier, are very well funded with government funding. So maybe this is already addressed in your market. But what about a collaborative model for contracting, for quality initiatives, a kind of an integrated model to really focus on contracting with insurers and working on quality initiatives in a collaborative model rather than individually? What about a revenue cycle process review, looking at front-end cycle, mid-cycle, back-end? Again, we see a 50% error rate within revenue cycle that could be improved through a revenue cycle process review. And lastly, what about a compliance program review? We've worked with a number of critical access hospitals that are paying money back today to the Medicare and other programs because they did not have compliance in line to bill accurately and effectively. Risk to the organization. So again, all kinds of possibilities to work with you as Wyoming Critical Access Hospitals to improve your bottom line through enhanced revenue opportunities. On the expense side, we can do a lot with looking at your staffing patterns in key labor-intensive areas. We can look at your cost per unit and look at your fixed cost and look at adopting innovative scheduling techniques for non-urgent services. Assess your staff by skill level. Do you have the right mix of staff? Could you better align staff more effectively while maintaining safety and quality? Or could you contract, rather than making services, dietary, laundry, and the like, could you buy services to create a more effective model of care? What about collaborative ventures for joint venture purchasing programs, or sharing some staff with other facilities or physicians with other facilities? Lots of possibilities and of keeping your cost per unit in line if your volumes are low, and that's what it's all about. And lastly, total facility cost and utilization. Could underused assets be repurposed, and how? And we could help you look at those possibilities as well. So there's a lot that can be done on the revenue side and on the expense side that we can talk about, and that's really what we want your input on in terms of what challenges are you facing, revenue side, expense side, that could be supported with the Flex program and projects that we could help put together for you. So that really gets us to the next step. We reviewed the full report with Kyle and her team in August. She's got the full report. And now we're really looking for input from you in terms of what might be beneficial from focused financial improvement projects as we move forward to the fiscal 2018 contract. So Kyle, I think at this point, I'm going to turn it over to you for the open mic so that we can have some open discussion.
All right, any comments, questions? You're welcome to type them in the chat box. Again, if you just look, if you scroll your cursor on to the bottom of your screen, you will see a chat box. On the left and right is your microphone and your video. So feel free. Any comments, questions? Is a collaborative possible? Any thoughts on that?
This is Maureen Cadwell. You know, I'm interested in a collaborative to share information such as benchmarking. You know, one of the biggest issues when you're a small facility is finding the right benchmarks for, say, housekeeping per square footage and those types of things. And so that's kind of what I would like to see or get more information on as an example.
Thank you.
And that's a great thought, Maureen, and there's a variety of ways at getting at that type of benchmarking information. One state that we work with has robust benchmarking, and we're in the process of putting that in a data analytical tool. That would be not necessarily benchmarking information specifically for the state of Wyoming, but it could be some benchmarking information to offer for the state of Wyoming to the extent that data is available through public means, i.e. cost reports. Whatever could be gleaned from the cost report could be used for benchmarking. However, we find it a bit inaccurate in some ways just because of how people are recording or reporting certain data. The state that I'm referencing that has a robust data set for benchmarking asks each of their hospitals to fill out and submit annually a template. And that template then is, in a sense, assembled, and that's what we're using, is data from that submitted information by each hospital to create some really innovative benchmarking reports. So to the extent that you as a community would be interested in populating something that would be maybe more accurate than the cost report itself, that would be an idea, if everybody was engaged, actually put the data in by virtue of submission and then reporting it back out by cohort. You know, maybe larger facilities, smaller, however you might want to define your cohort.
So Jane, does QHI do something like that?
I don't believe they do. I'm going to go and look, but I think their data is more of a higher level total organizational view. What Maureen is looking for is, how is her department performing? How is the dietary cost per day compared to others? What is the housekeeping cost per square foot clean versus, in a sense, maybe what you could buy it for? So it's really getting more to a departmental level than a total facility level.
Does that seem like it's something that the others of you who are on this call feel like you could benefit from as well? You can just write a yes or no in the chat box. And then, Jane, we do have two questions. I think they're similar. The first one is, will we have access to our facility assessment? And the second one is, when will we receive our individual facility information?
Good.
And we got two
Excellent.
yeses.
Yes. What we're going to be doing after this presentation, and Kyle, I believe that was your directive, is that after this presentation, we would be packaging the individual assessment reports for each facility and sending them out. And if that's still the directive, we could have those sent within the next week to week and a half.
Yes, yes, please. So we're getting several yeses on getting the benchmarking of departments. How would we move forward then with that?
Yes. I think we'd have to ask ourselves the kind of a initial question, and that would be, would the community of Wyoming Critical Access Hospitals be willing to receive some benchmarking information that we would pull together from what I would call a sample state? That's very good, but it's not Wyoming. Or does the community of Wyoming Critical Access Hospitals want to populate their data and send it to us, and we would then pull together the benchmarking data for Wyoming specific critical access hospitals? That would be kind of a fundamental question on data.
Sorry, I'm making notes. So, Chad, I think you're still on the line. I feel like this is something that we need to bring to Jackson next week. What are your thoughts on that?
Yeah, I think next week would be a great time to do it. We definitely have some time that we could bring that up, yes.
And maybe get some more buy-in, because if we do state specific, then we've got to get everyone on board. If we do just similar facilities, not so much. Chad, did you have something else you wanted to say?
No, I recall when we've gone to the Western Flex meeting, they always present us with benchmarks, and they do it with the cause that are attending the meeting, and also I think nationwide. And I've always found those benchmarks very useful. So this would be something similar to that, only within the state of Wyoming. So any type of benchmarks are, to me, are very beneficial.
Perhaps would you be interested in starting with more generic benchmarks from, in a sense, sample critical access hospitals from a state that does a great job collecting this information, and then moving to Wyoming benchmarks maybe as a secondary phase?
We belong, this is Chad again, we belong to an organization in the state of Idaho, eastern Idaho, and we do some of these benchmarks now, like cost per square foot for maintenance, or environmental services, and we, you know, so I know the state, at least the eastern part of the state of Idaho, the co-op, that we are doing some of these kind of benchmarking, and then we compare, have them, we all participate. I believe they send us out a survey, we fill it in with the information, and then they put it together for us.
Ah, okay. So you're thinking this could be similar in process to what Idaho is doing?
Possibly, yeah.
Okay. Is there a sample report that would be available to take a peek at and just see what they are benchmarking?
Yeah, I could get one of those.
Oh, that would be great. That would be great.
Let me make a note of that.
I have to, that's what I'm doing, making notes. So we have another comment or question. Are there any critical access hospital consortiums around the country partnering to create efficiencies? And will you please send this presentation out to us? I will try to send this presentation out to you. There's an internal process at the Department of Health. And as long as Jane is okay with me recording it and sending it out, I most likely will be able to. But so then going back to the question about consortiums around the country, partnering to create efficiencies. Jane?
Yes, yes. I would say the best state that we work with in terms of critical access hospitals coming together to create efficiencies is in the state of Illinois. The state of Illinois has a number of critical access hospitals, probably more than 50. I can't recall the exact number. But they've created an organization by the name of ICANN, I-C-A-N. It's an acronym for the Illinois Critical Access Network. What they've done as a consortium of sorts is try to come together to develop some innovation and shared learning and programs where it was beneficial to do it as a community of CAWs rather than a CAW individually. They focused on things like contracting, developing an accountable care organization, some type of risk-based organization where the CAWs could come together on a contracting strategy. There's lanes on quality improvement, so they're looking at care process cycles. They're looking at care pathways. So they're really coming at it from a care delivery model. They're looking at it from contracting with Medicare for some of the innovation programs, as well as insurers. And I believe they also are doing something with group purchasing as well in other lanes. So they've really, in a sense, developed a robust consortium for spreading some of the heavy lifting for fixed cost and innovation that would be very difficult to do as an individual CAW.
Did that help? Did that answer your question, PVHC? And then Kurt writes, I would like to see all CAW hospitals in Wyoming reporting benchmarks. Okay, great. I would like to see all CAW hospitals in Wyoming reporting benchmarks also. So, whatever we can do to encourage that and make that happen. I can certainly make sure that flex dollars are available for that. I think that might be one of the best, you know, between the benchmarking and collaboration and a consortium, I really do feel like that's the best use of flex dollars that have been allocated for financial improvement. So I'm more than willing to help, you know, do whatever I can to move us in that way. I again want to put a push out for QHI. Even though it may not provide the benchmarking, it can provide immediate reports back to you, showing any kind of financial risk that you might be at immediately. So again, I'm going to put that QHI push out there. All right. Any other questions, comments, anything else that you feel like we need to be talking about that we're not talking about? What's next, guys, then? I'm getting that we're going to look at benchmarking, we're going to look at collaborating on services and the consortium to improve efficiencies. We're good. Jane, any last words, any last comments for us? And
No,
do you have your contact information on the slide?
I believe it's right here. Contact information is there, so absolutely feel free to reach out if you have any questions on what we discussed this morning. We will be busy putting together your individual hospital reports, which will include this front section, as well as, rather than that sample hospital, it will be your hospital data. And again, so this is, think of this as just foundational work. And really the next part now is, now that we understand who you are, who you're serving, what your volumes are, what your financial strength is, now I think kind of the next phase of the benchmarking and the consortium in terms of sharing, whether it's sharing on services or innovation. I think there's a lot of possibilities for this consortium concept. And so I'm thrilled that you are all interested in it. And Kyle, we can sync up after this session and do some talking about the benchmarking concept.
Yeah, let's get started on that immediately. All right, I'm willing to let you guys all be free, but I do have a poll. If you could take just a minute, it's just 2 quick questions. Did you find value in this presentation, and would you attend another financial improvement Zoom conference if one were available? So if you just take a minute to answer that, and have a great Tuesday in Wyoming. And thanks for coming.
Thank you, Kaya.
You're welcome, Jane. Thank you very much.